is alive through the Endowed Laura Mann Integrative Healthcare Lecture Series, which brings distinguished leaders to the University of Vermont to share best practices, research, and innovations in integrative health and medicine. This series is hosted by the University of Vermont Integrative Health, a joint endeavor and adventure of the University of Vermont College of Nursing and Health Sciences, the Larner College of Medicine, and UVM Medical Center. It's my pleasure today to introduce Dr. Jeffrey Dusek. Dr. Dusek is a neuroscientist with a PhD in biopsychology. He has more than 20 years of mind-body research experience. For 10 years, he worked at the Mind-Body Medical Institute at Boston's Beth Israel Deaconess Medical Center, and for the past decade directed research at the Penny George Institute of Allina Health in Minneapolis. Dr. Dusek's work, much of which is funded by the CDC and the NIH, really focuses on effectiveness of integrative therapies delivered within complex clinical systems, and really has relevance to anyone conducting research in places where patients receive care, which is undoubtedly a very challenging situation. Currently, Dr. Dusek is at Connor Integrative Health in Ohio and is the clinical associate professor at the Department of Family Medicine and Community Health at Case Western Reserve University. Dr. Dusek?
Sound check. Is that working? Can you hear me? Okay, good. All right. I had a little coffee, but I did work out, so I'll speak slowly. But it's enthusiasm that brings me here. Thank you so much for the invitation to come to tell you what I've done for the last, 10 years on bringing integrative health and medicine to a complex health system. My tact is to do a lot of observational research. I've done a lot of randomized trials, but I'll talk about practice-based observational research today because I think that's where we are. We're at the point of trials are important and really impactful, but how do we actually tell the tale about what happens at the bedside or at the clinic level? So let me do a little moving forward here. Hold on, let me just get to the right thing. All right. I turned it off. All right. Thank you. Now for a brief talk. I hit the right one. There we go. Let's try that again. Hope that's recorded. That would be great. All right. So pain in America. I have one obligatory slide. Pain is an issue. I mean, clearly, we all know that pain's an issue. It's the cost, again, it ranges from $550 to $635 billion a year, coming from IOM. It's a main problem. The trick is, how do we control pain? How do we manage pain? And my tact, just to give you the take-home messages, I think there's a continuum. Some people need medications, some people don't need medications. I'm not one of these alternative medicine people who say it's just therapies. I'm saying it's a blend. Depending on where the patient is, we find the blend of where they need it. Some folks need a little bit of medication and a lot of integrative therapies. Some need no medication and a lot of therapies. So I think the fact is we don't come into a system and say we have all the answers. We come into the system and say, how do we blend in with what's happening already? Which is why the kind of research I do is, how do we add these therapies and use the things that are happening already as measures like pain scores to determine outcome. Excuse me. I'll calm down a little bit. So pain is a big issue, and of course, prescriptions and opioids. I'll talk a little bit about that, but that's not the focus. We all know that opioid prescriptions and use is an issue, and the fact of the matter is, can some of these therapies allow us to manage pain better and not use those prescriptions as readily? So the part I like about this particular slide from JAMA is, of course, basic science, where I came from, and then doing a lot of clinical research using efficacy and randomized trials to understand efficacy of intervention, A versus B or whatever it's going to be, is wonderful and really important. But all our goal is obviously clinical practice. How do we take what's in the randomized trial and bring it into clinical practice and actually find the delivery of the right care to the right person at the right time in real time? So that's the big issue. And of course, the translation between bedside to practice is challenging. You can't just run a bunch of trials and say, now just deploy it to the bedside and see how it's going to work. What we actually have is an opportunity to use practice-based research to do observational research, to be able to collect data at the bedside to understand what's happening. So we're looking for effectiveness versus efficacy, with the idea of translating to clinical practice. So what is practice-based research? Again, I will be very brief. I know a lot of you probably know this, but it's the care that's happening in clinics and offices and hospitals. This is not a randomized trial where we actually put an ad in the paper and want to have 50 people with high blood pressure come into the clinic and have a study of mind-body therapies versus health education. This is where we actually have people coming to the clinic and we're observing them as they go. So we're having questionnaires as they come into the waiting room, or we're having questionnaires as they come into the bedside. So we're actually looking to see how the care is being delivered clinically, and we're observing that as it happens. Advantages, so sometimes with efficacy, you can then look at effectiveness. So we actually would look at the effectiveness of an intervention after it's been determined to be efficacious. So we capture data in real time in real patients. So this is not this made up, 8 weeks where someone comes in at Wednesday at 6 o'clock for 1 hour of training. It doesn't happen that way. Real life doesn't happen that way, at least not in my family. It happens where it's 2 minutes here, 8 minutes there. So again, what happens as people are doing this naturally and clinically? And that we actually want to assess the intervention with clinicians in real time. So in fact, I'll show you some data that's being collected by acupuncture massage therapists at the bedside. So these are individuals as they're delivering care doing the data collection. And then it's actually supposed to be clinically detailed and patient level. So we're actually trying to get some details on individuals as they go through their clinical practice. The disadvantages, it's a little messy. There's not randomization in this case. Sometimes the clinicians aren't trained on data collection. I do a lot of work when we have people either in the clinic or bedside who are practitioners. We have a huge training manual on how to collect data. So again, we try to minimize that, but it is a challenge. And one of the biggest things is the electronic health record is a wonderful tool. It is not a research tool. And I do a lot of research using the EHR as a data collector. It is challenging. So we do a lot of modifications to that to ensure we get the data that we can use for our research purposes. And the informaticists tell me, of course it was not a research tool, but again, we'd like to be able to use it as such. So I'm going to give you 2 examples of integrative health and medicine where it's been deployed. One is where I was for 10 years, Abbott Northwestern Hospital, where integrative therapies are deployed at the bedside. And I'll give you some numbers in a few seconds. And then second is a practice-based research network consortium of 15 active centers across the country. And I'll give you an example of chronic pain assessment. So Abbott Northwestern Hospital, 630-bed hospital. The Penn and George Institute began in 2003 with philanthropic basis, also operational dollars, which are critical. At the time of 2016, it's gone down now because of operational challenges, but 2016, when I left, there were about 10,000 integrative medicine sessions per year. And there were no cost to patient. I've had given talks and someone says, someone's paying for this. And again, philanthropic dollars, operational dollars. It was actually, there's not like charge for nursing, right? So again, this idea of integrative therapies delivered to patients via referrals, there was no cost to patients. There was no People's Express. I remember those, I'm older than some of you, but going down the airline and charging for massage or acupuncture, there was no cost to patients. The average length of session was 31 minutes. And about 1.5 sessions per admission. So again, it's pretty robust. At the time, it was a little bit more robust, but it was acupuncture, acupressure, therapeutic massage, mind-body therapies, music therapy, aromatherapy. At that time, there are now about 11 practitioners, so circa 2016 there are 15 practitioners, massage therapist, acupuncturist, music therapist, and nursing. Actually, nursing had been much larger a few years before, but they actually moved that into the educational group. So 3 FTEs moved into education, how to train nurses at the bedside. There's a whole effort to how to train nurses to do acupressure, use aromatherapy. So I won't speak about that today, but there was another whole parallel path to having an integrative team, but having practitioners at the bedside being able to deliver aromatherapy at 11:30 at night. When a patient's at risk for a fall, a little lavender was able to get that person back to sleep versus giving a sleeping agent, which would maybe put that person at more risk. So again, a whole different pathways to think about how practitioners at the bedside can use these activities. This will be focused more on practitioners who are coming in for kind of the SWAT team. These are patients who are in really severe pain, and they're coming in to deliver this care based on referrals from physicians and nurses. So giving the I jumped ahead. The physicians and nurses refer via an Epic medical record to the integrative medicine team. And acupuncture, because in the state of Minnesota was under the Department of Medicine, an MD had to provide an acupuncture referral. The referral came in, let's say, overnight. The team would meet, 12 people around a table, taking all the referrals in, maybe 75 referrals in a day. They're divvying out, 12 times 6 people a day. They've got 72 sessions, so they try to divvy out new referrals, patients who are in the system. So they really try to use this triage system to figure out who is responding well, who is not responding well. They're actually trying to ideally get therapies to new individuals, especially when they're a lot of our spine patients were in severe pain. And so that was a huge unit that was really getting a lot of services. They go through electronic health record. Before they deliver any services. They're looking to see what was done before they get to the room, when were the medications given. They want to make sure they're doing no harm, and they're actually reading through notes. So they're doing a brief review to make sure that they are embedding into the care. Again, the referral came from a provider. It may have been anywhere from 24 to 48 hours beforehand. So make sure something didn't change since the referral came in and in fact, when they're coming to see the patient. They do an intake. There are a set of questions. The part that I built in was baseline data collection. We get pain on a 0 to 10 numeric rating scale, anxiety, nausea, and coping. Again, you'd say, Jeff, those are very short assessments, and saying absolutely, we want this to be part of the practice. We want this to be completed pre and post every time, and we don't want it to be a 15-item questionnaire on pain. By the time that happens, the opportunity for seeing the patient has gone away. So again, we use very brief measures, visual rating scales, typically, with the idea of having providers ask those questions before and after, and then document what the therapy was and all the different iterations of what happened in that session. So, as I said before, the sessions are about 31 minutes in length, and then they do data collection thereafter. So, again, they're really trying to chart right after. If not, they keep notes. If they're going to room, they'll chart as quickly as they can afterwards. So the IM provider is collecting the data before and after, which in some cases can be challenging. In some cases, it is realistic. But they document those scores. This is really hard to see, but this is an Epic flow sheet that we built. Excuse me. So again, it's got time, it's got visit start time, end time, things like that. It's got pain scores, anxiety scores, but it gives us a timestamp. So we actually use this when I work with the informaticists. It's really easy to collect the data. So it's a flow sheet gives us time limited scores. We actually are tackling a lot of the work in the notes part of the record, which is where a lot of the gold is, I think. But again, it really made my work a lot easier to use flow sheets because we can actually document quite readily. What you can see here is we did a lot of work on every acupuncture point, every meridian. So we have acupuncture points, needle depth, length of needle time. We have, if it was massage, it was the area of the body was massaged, the level of touch. So again, we really tried to get a sense of the dose that was happening across time. So again, it was really wonderful to do that. Part of our research, this is actually pre-NIH grant, was to look at 1,800 patients, just look to see what happens when integrative therapies are given pre and post. And we find that on a 0 to 10 scale, the trick was getting the providers to do this well, so it took a while to train them to do that. Once they did that, we actually got some really nice results. The interesting thing is people didn't go to the hospital for integrative therapies, so 65% of the people were brand new to integrative therapies. Despite that, they had about a 50% reduction in pain, pre to post, which was great. It was 1.9 units. If you're looking to the clinical significant levels, they range from 1.3 to 2.0, depending on the paper. There was actually a recent paper, a meta-analysis of clinical significant reductions in numeric rating scales that said 1.7 units is clinically significant. So again, 1.9 units gave us inspiration that in fact we were seeing something. The trick here was we couldn't tell if an opiate was given 15 minutes before. So my issue is I don't want to take credit for the integrative therapy. The massage therapist coming in saying, hey, I did a really wonderful massage. The person went from a 6 to a 4. We're not taking credit for that. So this is not controlling for opioids. We do that later. But this gave us some interest and enthusiasm that the interventions were impacting things in real time. And in fact, we could deploy a data collection stream such that we could actually collect information that was usable. So the questions were, is 1.9 units reproducible? Why do they receive integrative therapies? Does pain relief differ by therapy? Does pain relief differ by population? Might therapies work differently in different populations? Is it cost effective? What's the duration of pain relief? And does concurrent use of opioids influence pain relief in IM patients? A lot of questions. So we use those questions to pitch it to NIH, with these three being important. And I was able to get an R01 to do observational research study with the idea of using solid data collection approaches and solid rationale for why this is important to do a study for about 4 years. And we had three aims. One is to figure out the referral process. I won't speak about that today. We've published 3 papers on that. But the issue is, the take-home message is, nurses and physicians are noting that there are individuals, despite their best care, that aren't responding. And those are generally the people that get referrals. The folks who are sailing through and things are going well aren't referred. So again, the strategies when we spoke with both qualitative interviews and quantitative interviews, we were able to determine that there are whole pathways for when things are the quote-unquote train wreck patients are ones we get referred. And actually, the nurses and physicians really appreciated the opportunity to bring something to the table. For example, acupuncture was really, in a lot of conditions, able to reduce that pain and minimize the anxiety such that the physician said, it made me look good. I don't know what you guys did. This is a person that was really challenging, but you really guys made us look good. So again, the referrals, we studied that for quite a bit. We have about 6,000 patients working on a paper right now on 6,000 admissions, pre-post changes. And what I'll show you a little bit later is this duration of pain management. Because if it's 31 minutes, a lot of providers said, that's great, Jeff, but what about 4 hours later? So we actually have some data collection that goes out many hours and over many days. And I'll show you some of that today in a second. So again, we've got, but to do this observational work takes some time. So actually, we did some retrospective work, and I'll show you 3 studies on joint replacement, oncology and cardiology, and a cost analysis. And I'll talk about some ED work that we had done as well before getting to the durational study. So one of the most interesting populations was joint replacement. And there's a fast-track system at Abbott Northwestern Hospital where folks come in, and about 1.9 days later, they are discharged. And they're doing group PT, and they're doing all kinds of group activities. And one of the biggest issues was they said after group PT, there are about 8 or 10 individuals in a room in these lazy boy chairs that said, they are in so much pain, we are just opioiding like crazy. So they said, could you test out helping with acupuncture? And so group acupuncture protocol was delivered. And again, so PT would happen between like 3 and 4 p.m. The acupuncturist would go and consent patients and then go around. People could leave, and they certainly did, but go around to the room and deliver acupuncture over the course of about an hour. And what we saw was, between the pre and the post, about 45 minutes later, the decrease in pain went down from 1.9 units, roughly 45%. And the surgeons loved it. This was very much of a case that we have a paper on this as well, but we found that a lot of the providers were excited because the pain relief that they got from acupuncture after the group PT was brought up below 4, which was the threshold for do they need an opioid. So again, the idea was acute pain relief, but actually giving the option of not having that opioid. So if you look at any treatment of about 2,000 cases, 1.9 units, we actually broke it apart. Day 1, 1.7 units, and the people were actually discharged, so we didn't have as many people, but 2.14 units. So again, we published this in Pain Medicine in 2015, but very robust. It's still going on. It's really a very viable program, and again, very happy. Patients love it, and so do surgeons. So again, joint replacement, group acupuncture was very positive. Oncology, same kind of thing, 46% reduction in pain. So we just looked at oncology patients. And in anxiety, I didn't mention anxiety before, but we measure comorbid anxiety. So we're seeing anxiety going down dramatically. We published this in 2014. Again, just the idea of do oncology patients respond to integrative therapies. Finally, cardiovascular, same kind of thing. This is a little bit larger, and again, we need to do some future work to tease this apart. There's a lot of cardiovascular, is a huge umbrella. There are a lot of, we had some CABG surgeries, we had some PTCAs, we had a whole lot of conditions. But again, general trend is pain goes down, anxiety goes down. We publish that as well. We recently looked at cost implications. So the idea is these are therapies where either philanthropic donors are supporting this, or the operational group is doing this. And they said, is this cost effective? And so cost effectiveness is challenging. It's more cost mitigation or cost implications, because cost effective is a jargon term. But we actually did a retrospective analysis where we actually looked at demographics, length of stay. We used the APR-DRG to look at severity, because again, as I mentioned before, we were getting these really train wreck patients. We were curious if those severe patients, who tend to cost the system a lot of money, were impacting things. We had 2,730 patients who enrolled or were enrolled, and we looked at the demographics, pain score changes, length of stay, APR-DRG. On the cost, we got the hospital not to give us charges, because as you all know, charges are elevated. These are the costs. And we got the total cost of care, real dollar cost. And we actually saw that the pain was reduced 2.05 units, which was typical from what we're seeing. And if pain was reduced, this is the thing, if pain was reduced, we saw a consequent association of an $800 or almost $900 association decrease in total cost of care for that. We're using a proxy of the first time we received therapy. So again, the fact is, if we reduce pain, we think there's an association with reducing cost. And we just published that this past year. So it's actually very helpful. So that's the inpatient program. Again, joint replacement, cardiovascular, oncology, excellent. We built in data collection to the bedside. In that R01 I'd gotten a little extra a few dollars to deploy an acupuncturist into our ED. And one of the things I have to show you is our typical clinics are spacious, relaxed, quiet. There's nice music, softly lit, pleasant smelling. When we moved to the ED, it was cramped, stressful, loud beeping, screaming sometimes, brightly lit, offensive smelling, and you have to step over vomit. So it's challenging, and this is an example of, there's people in the room, there's a family member. This is obviously staged with our staff, but this is what it looked like. And this is the guide. It was a proof of principle. Could we embed acupuncture into the ED? And why we did that was, I went to college with the medical director. When I got to Abbott Northwestern, he said, why are we the stepchild? Why? We have high anxiety, we have high stress, we have high pain. That's just the staff. The patients then have that too. What can you do to help us? He said, how about I got some philanthropic dollars, NIH dollars, and said, let's get acupuncture down there. Let's just test it out. We'll have an acupuncturist embedded. Use this person as you see. And so the question, we had him down there for about 13 months, and the question was, would the patient, would PAs, NPs, MDs, and DOs refer? This is really small, but I have a lot to say. 73% of people on staff who used the roles referred for acupuncture over a 13-month period. We didn't know if that would be good or bad. That was much higher than we thought. Would patients accept it? This was interesting because they weren't coming to the ED for acupuncture, believe it or not. And when we said, would you want acupuncture? Does that mean you have to change your medications? Almost 90% said yes, which was interesting to us. We were excited by that. So 248 of 279 people who were approached said yes. Would acupuncture provide pain relief? We had 182 people who gave pre and post scores. Again, the acupuncturist collected them. And we had 49% who received a pain medication before acupuncture. Remember, I'm saying we don't want to take credit for acupuncture after pain medication. So we still collect that data. So the 49% who had an opioid or a NSAID before acupuncture were 6.8 on the pain scale when we collected it, and they had a 2.68 unit decrease. Now we had 51% who had no medications, and we went through the record, went through self-report. There were no medications on board before we saw them. They were 6.71 and had 2.37 decrease. So again, we didn't do statistics because it wasn't appropriate, but eyeballing this, you can say they're about the same range because we know 2.0 units is the high end of being clinically significant. So the other part that was really cool was in this no pain medication group, we tracked their utilization. 62% of those people then were discharged without any additional pain meds. Of the other 37%, 25% received an opioid and 13% received a NSAID. So again, the notion was, and not all these would have received pain medications, but the notion is, did acupuncture relieve pain? Yes. Potentially, did it help to alleviate the need for pain medications? Possibly. But it gave us some thoughts that was actually important for this. We published that right here in Pain Medicine as well. Again, a pilot study of retrospectively looking at this, so these are publications. But for a scientist, there was no control group, there was no comparison group, no randomization. The acupuncturist was collecting data. You know, gee, that was a great acupuncture session. It's not really a 3, it's a 2, or it's not really a 3, it's a 4, but I'll say it's a 3 because you're nice. So again, this idea of would they exaggerate their relief? The patients were referred by their physician. So the physician said, hey, would you like acupuncture? They're here, they're ready to go. Would that change the people's idea of how they responded? And then, so because of that, we actually completed our RCT, which I'll talk about in a second. So just to go through this very briefly, admit to the ED, the nursing staff triaged. We had a coordinator at the desk looking to make sure they have the whole set of eligibility criteria that we had. If the patient was eligible, obviously they're roomed anyway. They're roomed. We had a provider go and we're working with us and actually working as a team. And they said, if they're eligible, I will let you know. And we had them sign a sheet of paper that went in the record and scanned in, of course. So the provider would actually would help us to assess whether this person was eligible. We would then consent patients, randomize them, collect pre-scores, either go to acupuncture or usual care. About 40 minutes between pre and post for both of these. Both groups go back to usual care. We get a discharge score, ... 30 days later, we give them a call to see how they're doing. That was the that was the design. So in this case, we're looking for patients who are with really high pain, 4 and above, as well as a lot of things, you know, no broken bones, all these different things. I'll go through that. I won't go through that today, but we enrolled 46 out of 59, so we actually had a high recruitment rate. They're randomized. The average age was 36. Most were female, and most were non-white. Now, for integrative therapies, the female part you get. The minorities, we don't actually have a lot of minority acceptance of integrative therapies, and it's not acceptance, more of exposure. So really excited that, in fact, this was a female and a non-white population in this particular study. 23 randomized to acupuncture, 23 to usual care. Take-home message, both groups had high pain, 8.8, 7.9. Post-pain, down 3 units, down 1.5 units. ED discharge, 2.71 units down, 2.5. At 30 days, down 5, down 3. Again, we just were testing out to see what was going on. So again, we don't do any statistics because this was not, was a feasibility study, but generally, you know, 3 units at post-pain, 1 unit at post-pain, or 1.5 units at post-pain. We're excited that there's actually something there in a randomized fashion. So this is where patients were not asked by their physician. We actually had tablets, so we had the scores collected pre and post. We had no idea the scores would be clear, so we were blinded to their scores, so they could say whatever they wanted. We had no way of knowing what their pre-score or their post-score or their discharge score. So we actually improved the science. So there was no idea of them saying, hey, that was a great acupuncture. They could have said whatever they wanted to. So they were really, the patients were free to say what they wanted as far as the pain relief. So we felt much better that this was an accurate depiction of the pain intensity changes that were happening over time. So actually, I will say, so with this data, I just last Friday put in a UO1 application to NIH to do a multi-site feasibility study in preparation for a definitive study, looking at 3 different places across the country to run about 180 to 200 people in a preparatory study, just to make sure we could take this pilot data and bring it to 3 large centers to see if we can replicate that. The idea would be to run about 900 people in a definitive study in about 4 years. Science takes some time, I guess. Data collection, I promised you some this longitudinal data, the duration of pain effects. Again, this is just an example. We collected 6 pain scores at 30 minutes, 1, 2, and 3, 5 hours. We had tablets, so again, we're trying to not get in the way of the patient experience. This is our specialized database. Again, this is a lot of information, but we had time-stamped data, so we're really trying to be very precise in all this. And we have this is all kinds of things that are interesting to me, but not to you, but we had all kinds of rationale for doing all this. The point is, these are about 3,500 patients. We have a lot of conditions, so we've got the mother-baby unit, which is more antepartum. It's hard to really get into see 24 hours later a referral for in-labor patients. You can do the math. We've got, I'll show you the conditions later, but all these different conditions, pre-scores, post-scores, these are collected by the practitioners. So again, this idea of that 50% reduction in pain. The question is, what happens the rest of the time up to 5 hours? So in the mother-baby antepartum unit, it goes down. Now at 30 minutes, now is when my team goes out with research, the tablets. They have no link to the integrative therapy, so the patients have no idea they're being enrolled in an Abbott Northwestern pain study. It wasn't linked to the integrative therapies. Of course it was, but in the patient's mind, this was all through IRB approval. We did not want to have them feel like we were collecting information for the integrative medicine team, so we were really trying to make sure that we were ensuring that patients were not responsive because we were part of that team. So we actually saw a little bump up in that score. So again, is there a slight exaggeration going down here to here? Perhaps. But the good news is from 30 minutes to 5 hours, it's pretty flat. It's well below where it was to start. Now this group is more anxious than in pain. So they're going like 3.5 to about 1.8. So again, what about the other people that are not so in more pain? So we've got cardiovascular oncology groups, again, going down, intermixing, again, way below where they were at baseline. Again, still a little bump up, so again, maybe a slight exaggeration, but even if we just ignore this post effect, we've got pre and all the way out to 5 hours. Now we're getting to our other really painful conditions, orthopedics and spine. They're starting at round 6. They're going down to about 4. Again, that 2-unit decrease we're seeing, they do bounce up, maybe about 3/4 of a point, but it's pretty flat to 5 hours. These are, this group is all other. This is like your appendicitis or appendix surgeries and things like that. So again, the good news is there's a pattern with a lot of robust patients, blinded data collection in conditions that are very similar, again, a very similar pattern. Again, it makes total sense when you think of orthopedics where will one acupuncture session, one massage session change pain over time? Somewhat. Again, for us, it's this is the clinical significant level. So again, it's important. We have to figure out how do we work together with those therapies. As I mentioned before, we're not taking credit for opioids. This is all controlled for medication. So we have done, this is only integrative therapy. So we have dose, delivery, and pathway. So we have taken care of and controlled for any medication. So again, we're not coming in after an opioid and saying, is it massage great or is an acupuncture great? This is only the therapies. So this is actually important. We're actually working on a couple papers right now teasing apart therapies like acupuncture for conditions or massage for conditions and then by conditions. So we're working on 3 or 4 papers on this as well. So take-home message for inpatient care, reduce short-term pain as goes down and anxiety. I didn't show a lot of that, but focused on pain. Longer-term pain relief up to 5 hours was evident. The hospital costs, the association was pretty strong, actually quite strong. And again, the acupuncture was well liked by providers and patients in the ED. I mentioned the future studies are coming up. The multi-site feasibility is the next step, which I'm working on. After that, I want to do a definitive study in the ED. I want to actually look at the synergy between opioids and integrative therapies. So again, we have an opportunity with the medical record to know exactly when things were given. The hypothesis is that we think that integrative therapies, actually if opioids are given, that they can actually be a multiplier. So the idea would be to see if someone had an integrative therapy after an opioid, do we get actually combination relief that's exceeding both by themselves. We'll look at longer-term effects of anxiety and pain, and then cost effectiveness. The delivery of integrative therapies at the bedside needs to be strategized a little bit better. I mean, are there people that should deliver or get care on day 1 versus day 2? Again, this was not to that level of detail. But again, overall, at a 30,000-foot view level, this is very impactful for patients. There's some associations with patient satisfaction that we've looked at. Providers liked it. Patients liked it. So again, something that's very important. We want to look at the biological mechanisms of action. So again, the idea is what's happening, what's changing. So probably some salivary work that we would do in the hospital to determine that would be a next step. A lot of collaborators, of course, and funding by NIH to do a lot of that work. Second case, switching gears, is practice-based research in clinical cases for more chronic pain. And this is a case where we have a practice-based research network of 15, actually we had 18, but now 2 have gone away. We're now at 15 settings. We actually have 3 VA sites that are participating. They're very, very interested in integrative therapies. They have a very robust program. If you haven't had the VA come to talk to you, you should. Tracy Gaudet is doing great work there across the nation. We've got a pretty good racial mix across the country. We've got some in California. We've lost one in New Mexico, Minnesota, and New York, but we have a pretty good mix across the country of our practice-based research networks. Published some papers, cancer patients, pain patients. I'll skip through those. My baby has been PREMIERE, which is the Patients Receiving Integrative Medicine Interventions Effectiveness Registry. The idea is to almost replicate what I did in the inpatient program to the outpatient clinics. And we published this protocol in BMC CAM a couple of years ago. And what we're doing is we're enrolling people in the clinic prospectively. At enrollment, it might not be baseline because they may have been coming to the clinic for a while, but collecting data at 2 months, 4 months, 6 months, 12 months. We're getting IM services are received, ICD-9 or 10 codes, and CPT codes, again, with this idea of matching to see if looking at outcomes, patient-reported outcomes, and then matching those to their condition as well as what they received. We have some people who are going to be in the swim lane of just acupuncture, some who get a combination of different activities, some who go to integrative therapies. So we're actually determining, for example, chronic pain patients of like fibromyalgia. Is there a pathway by which acupuncture has more pain relief than others? And we're in the midst of this study. It's just, we're the last EHR extract. In fact, I was just talking to my team on Wednesday. We got 3 hospitals left to deliver EHR data. Otherwise, we'll be doing a lot of data analysis the rest of this year, but I can tell you where we are at this moment. So the primary outcome is to look at patient-reported outcomes over time. The second is to look to see if there are baseline characteristics that are different. And ideally, tertiary is to see whether interventions differentially impact PROs over time. Namely, does acupuncture, massage, or aromatherapy impact outcomes over time in populations? This is our recruitment. We've got some great sites. I left that off, but we've got Vanderbilt's one of our sites, Northwestern. We've got a lot of the UC schools. But we started this in 2013. We completed enrollment in 2014. Our 12-month follow-up ended end of 2018, so we're working on a data extract. But you can see we've got 5,048 patients. Again, enrollment is, it is what it is. We actually have a lot of information we collect from patients using REDCap as our platform. We have enrollment date, demographics, the PROMIS 29, which has 7 constructs, perceived stress scale 4, patient activation, primary conditions and symptoms, IM services received, and their new patient status. So one of the things, because it's a pain talk, we focus on the pain interference, which is the 4 questions on the PROMIS 29. How much did pain interfere with your day-to-day activities? Not at all to very much. How much did pain interfere with your working around home? Not at all to very much. Interfere with your ability to participate in social activities? Not at all to very much. Pain interfere with your household chores? Not at all very much. So again, this idea of a score. This is penultimate data. We anticipate having 2,000 patients in our chronic pain cohort sometime later this year, but I want to show you what we have to date. So it's rolling data collection, so this is not complete, but I wanted to show you what we have. So we have 969 patients who have pain of greater than 4 for 3 months. They had 2 surveys completed at least, and they had complete EHR data, and we're looking to see what happens with pain. So you can see this is the baseline. It goes down about 1.5 units, 2.5 units by 12 months. Clinical significance for this particular estimate is 2 units. So again, by 6 months, usually by 12 months, they are at the clinical significant decrease for pain interference. So at least some time for questions, so I did. So at PREMIERE, we're actually in a chronic pain cohort. We're actually able to determine that we're actually collecting data via REDCap, and we're actually finding a way to see some reductions in pain interference. We will look to see by the end of this year, hopefully, knock wood, which interventions are associated with most improvements, and is there an optimal dose? This idea is if people are coming to the clinic and they are randomly choosing therapies, we would love to find out if there's an optimal, for their condition, is there an optimal intervention, an optimal dose that in the future we could say, here's a best practice. So for example, if you have fibro, and our data from fibro says with 300 patients that acupuncture or massage is the most preferential outcome, we'd love to provide that the clinician to say, that's the referral we want to give. So we had this idea of people coming to our clinics and being able to choose what they want. We want to help to inform them with our data on what actually might be the most potentially effective approach for their pain relief. So all this is to say that patient-based research is invaluable because it actually gives us information that helps research, clinical practice, and operations. And we actually can use this information to inform future randomized trials. So for example, that observational data I did in the ED led to an RCT, which will hopefully lead to a UO1. So we use that observational data to go back and answer that question. Ideally, though, it can also help to uncover best practice. If we actually, in that premier study, find that there's an association with acupuncture, for example, relieving fibromyalgia better than others, we would use that information to help clinical practice to say, here's an option for you to offer to your patients. And then operations, we actually would like to figure out, is there a dosing parameter? So for example, in the in the Abbott Northwestern world, we are looking to see, is there a way to find patients who are more likely to respond on day 1 than day 2, or more likely to respond to different therapies. So we actually like this idea of this observational data either helping to help clinical practice right away or go back and help us to design a clinical trial to then go back to clinical practice. So the notion is practice-based research is an effective way to allow us to understand what's happening at the bedside or in the clinic. And I will, one last thing before I finish. There was, in 2016, there was a really nice article in the Mayo Clinical Proceedings, evidence-based evaluation of complementary health approaches for pain management in the United States. And that was cool, but the coolest thing was the JAMA editorial. As an opioid epidemic rages, complementary health approaches to pain gain traction. And what I liked is they actually spoke to the authors who were NIH staff members, and they said, unlike a typical systematic review that assigns quality values to the studies, the investigators conducted a narrative review in which they simply looked at the number of positive and negative trials. If there are more positives than negatives, then they generally felt the approach had some value. Based on a preponderance of positive versus negative trials, complementary approaches that may offer pain relief include acupuncture and yoga for back pain, acupuncture and Tai Chi for osteoarthritis of the knee, massage therapy for neck pain, and relaxation techniques for severe headaches and migraines. And the next step, they said, was, this was the director at the time, is to conduct pragmatic studies that look at the effectiveness of complementary therapies for pain outside of the strict inclusion-exclusion criteria of RCTs. We're looking to see how this works in real time, in the real world, with all the warts and all the things that go along with that, he said. At the end of the day, if this approach is successful, it will generalize it to most everyone with the disease versus a very small cohort of individuals. That's what I'm trying to do, is not look at the small randomized trials, but look at the large cohort and understand what's happening in real time with all the warts. So again, it is warty, but it is actually impactful. Thank you for your attendance. Any questions?
Thank you for your talk. That was really quite interesting. And I'm wondering, you said it on one tiny slide, what do you think the biological basis behind this is? Do you have any insights? What's the pathophysiology of how this reduces narcotic requirement or augments traditional therapy?
I can hypothesize that it's likely the stress pathways. So we're thinking of looking at cortisol is a really challenging assay to look at, but we're thinking that in the saliva, we'll probably look at Well, we're still debating. What I will say is when we look at these therapies in a laboratory setting, we see downregulation in 20 minutes of NF-kappa B. So we're seeing an anti-inflammatory effect that's related to potentially the pain. I actually think the anxiety is the driver of the pain relief. One of the observations that we saw in the ED was people who had the comorbid anxiety and pain were the most responsive. I don't highlight that as much because we're still trying to figure that out. So I think there's a whole exacerbation of the stress pathways. And again, I don't want to delve too much into that because we haven't done that enough. But I think that's where we're going to be heading down. But this idea of being able to look at expression levels with mind-body therapies and acupuncture and looking at NF-kappa B as the pathway is giving us the anti-inflammatory pathway is interesting to us.
Thank you. I know that you've been looking at pain scores, but my concern is people who are disabled, unable to work, unable to do household chores if they're not working. Have you been looking at those scores to see if the reduction in 1.9 or 2 is enough to get people back off disability into, working?
Great question. We have not, but we'll be well timed because we've got this data set I just spoke about. We'll be going through data analysis. We're working on that this past Wednesday, so I'll be sure to look at ADLs and make sure we can see if there is that relationship. Thank you for that. That's well timed.
Yeah, very interesting. Thanks. I'm wondering to what extent the placebo effect is involved in this. Not that there's anything wrong with that. If it is the placebo effect, that's just fine. But with acupuncture, for example, what if you were to, could you do some kind of a placebo trial where you stuck the needle in random places? I mean, not the eyeballs or anything, but, random innocuous places to see whether you have to be in the official meridians or not.
So you're talking about sham acupuncture. We've got a person who could speak to that better than I could. We actually, the placebo effect is real. And in fact, it is a very solid mind-body effect. We also know that it also affects that NF-kappa B pathway. We elected not to use sham acupuncture, especially in the ED trials, because we talked to the clinicians. They said, number one, the evidence is there that acupuncture is different than sham acupuncture. But they said, we really don't care. We want this to be as good as opioids. We don't necessarily care about the mechanism of action. We don't care about the pathways, or we don't care about the placebo effect, as it were. We're really interested to see if you could offer us a viable alternative to having, to only go to narcotics. The ED friend of mine said my favorite line is, I'm just tired of narcotizing my patients. Give me something that I can use that will allow us to not have to provide narcotics for conditions where they're not necessary. Abdominal pain is really a big one that came in. So I think I'll dodge that question just because I think Robert can answer that better. But I think the fact is we can get down that pathway of worrying about whether the mind impacts the body, which it does, and worrying if there really is an impact. I like the proof in the pudding is if we're seeing equivalence. That's what we're looking for. We're looking for equivalent pain relief to usual care. I think that's my personal tact. But it's an important consideration for some folks, and we'll just have to table that for the moment. But thank you for the question. Yes.
Thanks very much. Super interesting. I have kind of a practical question. Throughout all of your slides, I was really struck by the enormous sample size and the success that you've had enrolling patients into these studies. And I wonder if you could talk a little bit about how you got such good buy-in from, all different kinds of providers throughout your various clinical settings, and what the barriers and challenges were to that, and how you overcame them.
Sure.
I think in our setting that would be one of the hardest challenges. It seems like you've been super successful at it.
Okay. So I'll talk about the Abbott Northwestern example first. I came in 2007. The operational lead was a lioness. She had champions all over the place. So when I came in to do the data collection, she'd already set up the fact that this was an important service line. This was, it was a service line along, as anything else was. It was an important, thing. So she got buy-in from, at that point, about 1,000 physicians and nurses to refer for services. Where I had to do my work was on the providers themselves, the acupuncturist, the music therapist, the massage therapist, to say it's really important for us to ask the questions reliably, the same way we ask 0 to 10, 0 being no pain, pain being maximal pain, every time the same way. We don't ask at the end saying, is your pain still the same? We don't ask, how are you doing now? It's reliability and reproducibility. For that NIH study, we had a manual of about 180 pages. We went through many, many trainings on how to document the medical record. So we built the record collection process from scratch, and we made sure all the providers repeatedly knew how to use that, so there was documentation. I was blue in the face for a lot of time, just saying, look, folks, I am trying to help you to understand the impact that you're having at the bedside, and if you don't participate, we don't get anywhere. So I really was consistently persevering them, I can't even talk anymore. I was persistent in determining that we needed excellent data collection. So I really got the buy-in from the providers by letting them tell the story numerically. They know that that's but 1 score or 2 scores, but I really wanted to get buy-in. On the other hand, with when I've gone to other places, it's really been the data saying we're not proselytizing. If we don't see something, we're going to say it. We're going to publish it, and we're going to say, something didn't work. So this idea of being scientists and being honest brokers, we come in as saying we're going to tell the tale as it is. Had that acupuncture study not worked at all, I would be up here saying it didn't work. Had that long-term pain relief study been flat or gone up, I would have shown you the same thing. So again, we get buy-in from the informaticists, the physicians, because we're saying we're as interested as you are, and we don't want to delude ourselves or you or the patients. If nothing's there, we'll tell you. So again, I think that's how we've done it, is being completely honest and being transparent, and also publishing everything we can regardless of any outcomes. So I think that's been the best way to do it, is being honest brokers. In the back, yes. So if you didn't hear that, I really poorly said what I was trying to say. So the person called me out appropriately, saying women do not complain about pain more than men, and minority individuals have pain. Is that correct? And I misspoke. What I meant to say was a lot of the studies of integrative health and medicine enroll women more than men, just because that's how this research goes. I actually have flippant part of my talk is my wife is a yoga therapist and says, Jeff, you guys will get there, you're slow. Men are just slow to this. I think men and women respond equally to these therapies. I actually ran one study in Boston with prostate cancer patients. Relaxation response, mind-body therapies, Reiki, and weightless control, or no treatment control. We found equivalence across the Reiki and mind-body therapies, really great response. And we had men at the Dana-Farber Cancer Institute. We tripled our enrollment as twice as fast. Men were interested to participate. So it's more that we don't have participation from males. And the clinics that we have mostly been studying have not had a good representation of minorities. My point is, especially as I'm putting this grant in, our goal is to study women and minorities more than just white males like me. And so my point is saying I was really excited that in that study we found great response, we had great participation, and we are looking at groups that are obviously underrepresented in research. That was my intent, and I do apologize for misspeaking. I think absolutely women, minorities, males, majorities all respond or can respond, and we need to study that. So my intent was, and I do apologize for misspeaking, I was really hoping that our field, and I'm hoping that our field broadens what we're doing. There's a lot of work to bring integrative therapies to underserved populations. There's a lot of opportunities to find ways to scale costs and bring opportunities, so looking at group-based opportunities. So again, let's not have income or where we are located be a barrier. So my intent is to not do that, and I do apologize for misspeaking.
I think we'll stop there in the interest of time, but please come down and ask questions.
Besides turning it off, that was, and I will take this out so I don't forget
good.
it.
I'm glad that you remembered.
Hi, thank you.
Jeff. Hi.
I'm a medical student here.
Oh, nice.
Just what I wanted to ask to the whole group was how can our medical school and health network contribute to this research? How do you see us fitting in?
Good question. I would say participate. I mean, so are you involved at all in? We have a whole consortium of schools, and Vermont's part of that. There are like monthly calls to be involved in. There's yearly meetings. We need students because you're going to be the leaders thereafter. So I'd say participate in that group. So I think that is where your voice, as you're finding your colleagues, you're going to find like-minded people. So that'd be my.
Say the name of it again.
It's the Consortium of Academic Medical Centers. I can get you the listing, but that would be the great way to do it because that's Consortium and Integrative Health and Medicine. You'll pop up and you'll see that. And you guys are members, so you guys, as a member school, you have access to all the things. There's a clinical working group, a research working group, a policy group. So that would be the best recommendation I have. Yeah, thanks.
Can I just steal the microphone? Unless
Oh, you want that back?
As a party gift.
I'll go to the restroom. Whoa!
Thank you so much. Yeah, that was great. So I'm a DO, not an MD, and I trained in Maine. And at Maine Med, they have a really pretty robust OMM consultation service. And you
DOs
just-
you get way more exposure.
Yeah, and when for my so I went to UNE, which is in Maine, and our medical school requires us to do some sort of osteopathic rotation as a fourth year, and I did it at Maine Med on the OMM service, and they were just starting to integrate it with integrated medicine like acupuncture and Reiki, and it makes me sad that we don't have that here because it was so helpful.
Yes.
You know.
Great stuff. Thank you
Thank
very much. I wonder what you can say about dosing these therapies.
That's exactly what we don't know. So right now we don't. I don't figure out exactly. Does someone need 2 doses?
Right.
And again, if we're studying the right therapy with the wrong dose, we're screwed. So I'm totally on board with dosing.
You know, I'm from Germany, and my parents are still there and are very elderly. And my mom has lots of back pain types of stuff, and the German health insurance pays for massage therapy.
They do, exactly.
And so she really, it's used as a maintenance treatment, not as a ×1 and then you're going to be
Yep.
fine. And that makes a lot of sense that you would need some sort of maintenance
Exactly.
to keep that up. And I wonder if we have any evidence or any data about that.
Not yet. We'll have some with this premier study because it's the largest study of its
Yeah,
kind.
yeah.
We'll actually probably a big pilot.
Yeah.
We want to figure out exactly because we have even within that we're splitting out the maintenance people versus the acute. So we'll have that chronic pain group. Will have a little bit of both.
great stuff.
Yeah, but it'll help to figure out. What I don't want to have happen is people go to the clinic and say, "What should I do?" And we give them the wrong thing because it's not going to be cost effective. You need to try like 4 different things before you actually get the right thing for you. We're going to be the money's going to be gone.
Yeah. That's great.
Okay.
Thank you very much.
Absolutely. Thank you.
Hi. Hi, Jeff. How are you? Good. Lecture. Thank you. I'm the chief medical officer of the Cross. We've been working but I know you're spending a day with these guys, which is great. And I would assume that if we were to go out with some of our other discussions well, have a good day. Nice to meet you. And I'll give you a call. I hear the voice. Okay. What's your job? Thank you. All right. Thank you. Take care. And it's really you saying, yeah, no, I could. What I originally I'd like to talk to you about one, right now that the state finally, just now, they have their RFP out for that money that the legislature they decided to put an RFP out. You remember you and I conversed about whether we could use some of your data and whatever. So there's
I just wanted to say that was really great. Oh, really interesting. This is just totally aside question. If you had seen integrated therapies for restless legs, like to quality of life and things like that. Yeah, but haven't so much.
Yeah.
Okay.
No, I haven't, but that's a good.
No.
I'm intrigued.
I mean, all of this is so intriguing.
Just to say that I have
And again, the point is, we're coming in as a team. So much of it is like, oh no, we're in a position anymore. Like, we totally need to be a team.
No, there were so many interesting things about the research model and
I think
approaching things from a sort of workflow, normal clinical exposure patterns and things like that. Those
but really the only data
yeah,
that's
no,
there
I
for
think
data,
probably there were a lot of very, very interested minds in there. So thank you so much.
You're welcome. Thank you.
so they might have control.
Well, I'm just trying to think of who would be the right people or is it just very she's a health services research person, Eva. She's done a lot of cost studies.
We just opened up
She's active
and are going to be developing an innovation for that. So you should talk to when that happens. Well, yeah, and we should talk.
to find out who and how.
Yeah. Yeah, Steve, I haven't met him.
Danny to be here.
Yeah, there's more and more deals. Good, we need more deals. Yeah, they're the way of the future. Nice to meet you, Heather. All right, Jeff.
All right, so I think that, anyway, just to let you know, I think that today is their question deadline, and I think February 22nd is when that RFP is due or whatever. So I expect that, it's unclear to me how this all is going to work, but I think, but the basic, they issued the RFP as if it was for a prospective study, and the truth is there's not enough money for a prospective study. So I think these respondents are going to say, we don't think there's not enough money, but we think we might even get better answers retrospectively. Yeah, and that's what they're going to pitch, and I hope Diva accepts that. So we'll see. But I think definitely you guys have more data than Diva does.
Do you know who the administrator of the RFP person?
I'd have to look it up. It's a woman's name, and I don't recognize it. I could look it up.
Yeah. So when we touch base on this other thing, if we could get that information.
I think it's
in the
just.
meantime, I'm going to talk to Mary Kay.
Okay.
Why not?
Yeah. think if you, I don't think I'm allowed to, while the RFP is out, I don't think I can talk to anybody from DEVA anymore. But I think you could, and I think maybe I will, if it's okay with you, I might, the people who are issuing, who are going to respond to these RFPs might have questions.
Sure.
Would that be okay?
Yeah,
Okay.
of course.
Cool. You want to contribute to the, the other thing I would say is sort of like you would probably disagree with me, I think I was what I'm about to say, but my feeling is, to some extent, that the payers, especially Medicare, possibly some of you guys too, sort of have used the plan as sort of like, well, we're not ready to move forward on that, but we'll do this. And yet, the clinic isn't working as it should, because we have hospital administrators who, like, there's no money there, we're in this chicken and egg.
Right. So I think the reality is that the hospital administrators are waiting for us to like link a contract and with them for an exact amount for the episode, which we are doing.
Yeah.
And actually,
Well, I think-
on Tuesday, just so you know, transparent, right? So on Tuesday, our contract folks are meeting with the health networks contract folks to finalize an actual number, cost per patient that we are going to pay. In fact, the reality is the negotiation business work together and develop is quite collaborative. And they threw a number back at us, and we looked into it, and it was like, okay, let's go. So but they have to go through that, and until they have, I imagine, I can't cast aspersions to its but
Yeah.
but they want to have a guarantee before they sign contracts to spend money. So I'm not
I'm saying more than I'm supposed to say, but it's not, I don't feel like I'm being, like, I'm not a party to it, so I'm just.
But you also understand that, again, let's go back to TIVA. So they had their RFP, which Beth has not been able to get. So she's working to do that. She expects to do that. Maybe it's by June, but it's all maybe. We're in. So I get that these guys go, well, TIVA hasn't found money. Plus, I didn't sign the contract. You can't start hiring contract. I get that from a business perspective. Anxiety on your
Bad
part.
for the morale of the whole clinic, it has stalled us. My thing is, we're talking about this, here's
Well, there's another thing, maybe kept me just thinking about morale. Would it help for me to come to the clinic, one of the clinic meetings, and just talk about what disease and our commitment to it?
I think so, but we should ask John.
Well, John, yeah, of course.
And I think he would probably know that.
I mean, I'm happy to do that if nothing else for my group.
Yeah, and I think we recognize that Blue Cross is doing well, but that's a subset. Here's the problem, and this I think is truth that many people have concurred with, is that we what we promised by the hospital was it's okay for hemorrhage for the first few years. You understand, right? We're going to let you do what you do, collect data. Well, that changed a few months ago. I'm not sure why, except for that they're under budget pressure. You know what I mean? Like all of a sudden,
was the VP population.
And now he's
the
going to be
CEO
the temp-
here. Think measured, of course, but Steve is behind this kind of work.
Yeah.
And that's the leverage it would take for Steve to kind of ask Steve to go to these equipment and say, you need to do this.
Yeah.
And that's
Well, that's what I when I heard the transition that was going to be occurring. That's what I said to John. I said, "Is this going to be helpful?" And they're like, "Yeah, but I don't know that that's really his job."
No, it's a big organization, but honestly, he does a lot of things. So I don't know the structure. I'm not familiar with enough of the structure. John reports to Tom Peterson academically, but he reports to someone else operationally. So.
The two other things I'm working on, I'm deep into this conference right now. Yeah, I think it's going to be a really cool conference. But I want to talk to you about a couple of the panels that I'm going to be on, because I'm going to talk a little bit about Blue Cross and the report and the response and stuff like that as an example, along with examples of other things like the Joint Commission. I have the people who affected the change in the Joint Commission guidelines and stuff, and talk about that.
Yeah, MBA folks as well.
Yeah. And I think we're even going to have somebody from CMS there. But the other thing we're working on is there's this RFP out. I don't know if you know this, but I think I might have told you, but NIH has an RFP out for a pragmatic trial for acupuncture for low back pain for seniors, which is designed. CMS is right now doing another review of coverage analysis for acupuncture for low back pain. And it looks like they want to use this trial. So I have a bunch of colleagues who are applying to this, and I'm sort of involved with that.
And it's same like Cindy and Brenda, that same group of folks?
No, it's, I mean, the Society for Acupuncture Research, I think, is going to consult with a team from Duke and UNC and all that. But I know there's a powerful group up in Washington State and one at California and Stanford and UCSF. So I don't know who's going to get the awards, but I think that's going to lead to Medicare coverage of acupuncture in about 5 years' time.
Oh, yeah. Well,
By the time they complete the study.
sorry.
But, yeah.
So,
But it'll probably be limited to back pain.
well, but I think there's movement, and I think the movement could be catalyzed. So yes, CMS is going to have to do a study, and certainly that's a good thing.
But
I think the
here's what I
commercials-
predict. Here's what I predict.
Yeah.
I predict by July. See, that's when CMS is going to put out their initial,
RFP.
no, their initial statement position, and then October is when it's formalized. And I bet you it's at least going to, I'm forgetting the terminology, but there's a terminology where they say we'll cover it as part of a study.
Coverage with evidence determination.
Yes, coverage with evidence determination, I think, is going to come online. The timing's a little off because people have to put their grant budgets in before this happens. But they were like, whoever wins the award will work with you. So that, you know what I mean? So that the grant doesn't have to pay for the treatments.
Right.
But you can imagine from your perspective with your peers trying to make a case, if Medicare makes this determination, it just helps you.
Well, and the Blues have talked about this very concept, and in fact, we do provide some coverage with evidence determination, informally, if you will, for some services here in Vermont. The Blues are starting to formalize their approach to coverage with evidence determination. Blues are like Medicare, the Blues are different companies. And so, and we don't talk to them. So it's not actually perfect. So, one could consider the pain planning coverage as coverage with evidence determination. One could consider this covering a panel for targeted therapy cancer here as coverage with evidence determination.
Right.
So, because there's not definitive information on long-term health outcomes. So we're quick to go, yeah, sure, we'll do it for those guys. It's actually a vanishingly small portion of the commercial population.
Right.
Over the past 5 years, you can see that the self-funded groups have gone through the roof. So the self-funded groups the decisions are made by the director of HR here at UPM Medical Center. And so you have to make a very cogent case of really around cost, even more so than for us. Interestingly, you thought we were short today. Talk to the director of HR. They're looking at their yearly budget, saying, well, we're willing to make an investment and see if that pays off in 5 years, but those guys are not.
I've always thought it was so weird how the hospital covers it, but the university doesn't.
It is bizarre, and they have different benefit, different benefit managers. So it takes many runs of this with different groups to do change management.
Yeah. So I would love sometime very soon to sit down and focus on our conference with you to give you a sense of the program, what we're trying to accomplish, and get your advice on it.
Sure.
Because I think we're trying to put together some panels that I think are pretty unique, and some that are evidence oriented, but some that are very patient and practical oriented that talk about clinical, but also administrative barriers to get here, but also talk about this. Like a big focus is dissemination of research, and you can do that top down. And you can also do it bottom up, and you know what I mean.
And you may need to do both.
That's right.
Yeah.
That's right. Right.
And so what you might want to do, I'd be happy to do that. I remember the original stuff, and that was a while ago. You've obviously evolved your thoughts of how you want to present this.
Yeah.
So if you have any current kind of summary documents or something that you want me to review, and then we can talk, so I can have just a framework.
Yeah. Well, tell me what you're talking about. This talk now.
We'll hear the talk. Yeah.
How long should it be, or what's the optimum?
Well, no, I'm sorry. I'm talking about the conference.
The conference.
The conference.
Okay,
I'm focusing on your question.
Oh, sorry.
So, because then we can find some time to just go through that, and I'm happy to help you work through it. I just want to see where you're at now.
Yeah.
And then for this thing, for presenting to us internally, no more than an hour. It's really probably
Would it be better to be less than an hour?
Yeah.
Like, what's the optimum time?
My thought is optimum 30-minute presentation,
Yeah, okay.
30 minutes for discussion.
Okay. Yeah, all right.
Yeah.
I can do that. I've
20
I've
slides.
talked about this so much over the last year in different venues, and now one time it's an hour, one time it's 20 minutes, and so.
Yeah, these are like contracting folks and benefit folks.
So this
Really
isn't
interesting.
So, and it's not. It's
The leadership.
the audience is more.
It's a cross-functional leadership group, which includes both clinical, marketing, contract, product, folks all in the room at the same time, quality folks. And we literally kind of work through issues, because I'll say something stupid and lawyers do that. So it is actually a cross-functional
No, but it's
decision-making.
That's helpful because everybody's got their, what about this?
Exactly.
Yeah.
And that's the group that makes this, it's one of the groups that makes the decisions about, do we go forward with this? And at the same time, you have to do change management with one person at a time. You actually have all the decision makers in the room at the same time. And then the follow-up with each one of them is going to be the way we cover this one.
Okay. But yeah, I just want to help. So.
All right, so I'll set that up. I'll figure out a date.
there'll be somebody here shortly. Get all the slidage and all that stuff taken care of. I'll introduce you to my chair, Bob Curtini. He's a very good guy. And I told him, he and I meet every 2 weeks for an hour and a half and it's about plot. And I've told him about the Alameda thing, and he's a good guy.
Yeah, good. Good. All right. So I just.
Yeah, that's the usual stuff, right? You got your lavalier mic, you got your stuff. You can see your slides here.
Yep.
And then they'll tell you they'll be broadcasting to a couple of other locations, which doesn't make any difference. Yeah. Let's see. What do you have your stuff? Is that your stuff there?
That's, yeah.
I bet you. Here it is, right here. So as soon as somebody comes in, we just put it on there, and let people do their thing.
Hi. You're Julie?
I am.
I'm Adrian.
Nice to meet you.
Nice to meet you.
Thanks so much for coming. How was your travels? You made it. You're very good. This is for you.
Oh, wow.
Coughing, choking.
Yeah, that's good. Probably lots of that, yeah.
How's this? Is this behaving or how are you doing?
Oh, well,
So
I just brought
Good.
this.
We're
So.
gonna,
There we go.
the guy, I just saw the guy in the hall. He will
Perfect.
come and help us. You see?
You've done this before.
I'll just press all the buttons. So go
There you
ahead.
go.
Plug yourself in here.
Just plug this in here?
Yep.
Okay. Very high tech. Not a millennial.
No, right. You have to do it like 3 times for sure. Okay. So this you?
Mm-hmm. That's it.
Here we go.
Voila.
Just continue to ignore this. And it will be right here for now, but if you want to see it up there, I'm just going to put it in
Yes.
slideshow mode.
Yeah.
Woohoo! It's working.
Woohoo.
It's behaving.
Yeah.
That's official.
It is.
All right.
Wanna
Done.
flip-
I don't need to do anything. They can just read the slides.
Yeah. All right, there you go.
you
That's
go.
fine. And then this is then your next slide. This thing works by being your next slide on it.
Yes.
That's annoying. I recommend using the keyboard.
Keyboard, click down.
It's up to you, and I think maybe you can pull it up here.
Yeah.
And you can go down or over, whichever one you want, and then easily go back if like you get too crazy with the button
Yes.
pressing.
Okay.
And then I'm gonna turn this on to, that's not it. I just can never remember how to do this. Oh, laser. No, I think it's pen. Nope, it's laser. No. Highlighter. Nope. Okay, sorry. I'm just pressing. Good thing we're not doing this in front of people. Okay. So if you want to point to anything on the slides, I recommend using the mouse. And it's in this, they're videotaping your presentation, and so it's easier for people to see this thing than a point, if you have a pointer.
Right.
You know, so.
Right.
So
Okay.
that's what they, and you just push it out of the way if it's in the middle of things. Oop, God, I'm just messing things up.
Okay.
All
All right.
I'm gonna run through your stuff.
Yeah. Cool.
Oh.
All right.
All right, what else? And before, 5 minutes before, we'll plug you into the mic and we'll do that.
Cool. It's a clip.
Exactly, yeah. And do you have a pocket, or do you have? I think
I have a pocket.
there's a clip on this too, but we can figure that out.
You're prohibited from saying, "Is this thing on?" You can't do it.
Can you hear me? Right?
Right.
Can you hear me now?
I shook through it.
Okay.
I'm going to show you what the bathroom is if you want that.
Oh, that would be
Now,
great.
you ready for now? Okay, yeah. All right. So we won't mic you up till
Right.
That's a favorite joke I make every week. I'm gonna be warm if I wear my jacket. Is that okay?
Oh yeah, no worries. Whatever you're comfortable in is fine. People do all kinds of different things. I was trying to find my tape to tape something on the wall. Okay. High tech. Okay. All right, bathroom is right up here. Where'd you guys have dinner last night? Oh yeah, yeah. Was it any good? Very nice. Yeah, good. Yes, I've heard good things. Oh yeah, really. Oh yeah, yeah, right. Dinner?
Nice. Yeah, I went to the Guild.
Oh yeah, I've been there.
Which is, that's nice.
Yeah,
It's
no, I've heard all the good things, right?
Convenient, right?
Absolutely, yeah, easy to get to, yep.
Yeah, it's nice.
Easy to park at.
Mm-hmm.
All right.
How are you doing?
Good, good. You have her intro, I brought one just in case it got eaten by a dog or something. Do you guys know each other from elsewhere? Or
We
just,
do.
Oh, you do? Oh, good, good.
So she until very recently was worked for the Department of Justice.
Right,
And
exactly.
I consulted with them.
Okay.
Out in California.
Sure, sure.
And then she asked me to be one of the readers for her master's degree.
Oh, good, yeah,
And
great.
So I read this thing
Sure.
and I said, oh.
We need to hear about this, right? right. Great, great.
Very nice, nice person. The real deal.
Yeah, yeah,
Sure
good,
is.
great. What time is the flight today? Is that?
It's like 4:30 or something
okay.
like that. So
No rushing,
she's
no running around.
probably gonna just like camp out in the Davis Center or something
Yeah,
like that.
sure, great, great. Recommend if the airport has good beer, depending
That
on
too.
what she likes, right?
Absolutely.
Right. After a camp out.
So how are you liking this role?
It's fine. It's good. And losing Anne last July, so like doing all the administrative stuff is yes.
Right.
But now it's like it's too hard to like teach. I should teach Melissa how to do it. It's just there's like she still doesn't have access to the web, the lists, so it's sort of like now that I know what I have to do, I was like go figure out how to get yourself access, but I don't have all those permission things. So. It's fun, and we're booked to the end of this year, so I'm like, oh, I just have to manage the day-to-day stuff. And of course, the opposite thing, like, hey, do we have any spots in April? Like, no, don't. Oh, yeah. We use some, like, potential faculty hire he wants to get in. There's a child-related thing. So it's like, how about Tom Achenbach? Always this discussion afterwards. The
residence and fellow. The end of the year is the easy thing. Hello.
Trying to get some of the sunshine.
Yeah, right. Yeah, it's good efforts, right? And remember, no window.
It feels like early spring.
It sure does. The sun is not yet walking over. It's
I think it's
beautiful.
supposed to be cold, right?
Yes. Oh, and windy throughout the day. It's supposed to be gross, but.
Everyone good? A little
Yeah,
ready to
she's in
go?
the bathroom. I think we're all good. Everything seems fine so far. Knock on wood.
Absolutely. It's Friday, so it's
Yeah.
it's a good start.
Right, right. Thanks. Where do you hang out most of the time? Are you over here? Are you everywhere?
I have a team over in the Hills building.
Oh,
We do
okay.
the Veterans
Yeah,
Project
yeah,
over
right,
there.
right. I noticed there.
And then I do, like the medical director thing for Pathways Vermont.
Right, okay.
But much of my time now is this other stuff, this sort of spin-offs.
Oh, good. Excellent. Good. Fingers crossed. Good, we'll take it.
In the fall.
Good, good. Well, we're wide open, so.
Excellent. Very cool.
Where did you're in Baltimore now, is that right?
I'm in
Where did you
Baltimore.
move from? Where?
I was in DC.
DC, okay, so not
Um,
too far. Could have been worse.
It could have been worse.
Could have been farther.
Yeah, no, the big move was New Hampshire to DC.
Okay, sure.
Which was like 3 years ago.
Yeah,
Yeah. I got out of the federal government right before the furlough.
Yeah.
Right.
Missed all the
Right,
fun.
that's good, right,
Yes.
you're missing the
Yeah.
excitement, huh?
But you did get a parting gift of a portrait of the Attorney General.
That's,
The
yes.
acting Attorney General.
Right,
and-
right,
Yes.
yeah. No, well, they were getting rid of all the Jeff Sessions pictures, so I just took
see.
one with me.
Yeah,
It's like
but-
history or something, yeah, right, some kind of history. Did this really happen?
I'm telling you. All right, so now that I've had coffee, one more time, IDD.
Intellectual and developmental disabilities.
All right. Yeah.
So, Adrian, here's the clock right here is our official game clock,
Yep.
game time.
Yep.
And we have the room till 11:45, and then the
Okay.
neurology people get in and want to kick us out. So,
Okay.
I'm not sure how long you plan your talk is, but
I
generally.
haven't really timed it. but
Great,
we'll
great. So people, there's always good questions in the audience, so
Yes.
leave some time. Generally, people talk for about an hour, and then 15 minutes or so for questions. So whatever works for you, that's good.
Okay.
There'll always be questions.
Okay.
Folks like to talk.
Okay.
And that's about it. They're broadcasting to our outlying sites or people in their offices, too lazy to walk down. So that'll just happen in the background. You won't notice anything about
Okay.
that.
Okay.
It'll just be happening. And that's all, I guess. Anything else? Are you all good? You got.
I think so. I'm not really sure how long the presentation will take, so, I'll just get through it when I get through it. And then
Sure,
I'll just
sure.
do the rest of the time talking.
Yeah, great. That's fine. There's lots to talk about.
More there than I did.
Attorney General.
Right,
Speak
right.
on their feet.
Right.
Well, yeah. Or I can say, well, I'll have to get back to you on that.
Right, that's fine.
Or,
That's
or
better
the
than making
best
it up.
attorney line is, well, we can agree to disagree about that.
That's a good one. I like that one.
I thought that was a couples therapy.
Yeah,
Well,
some folks in
there
this
you go.
audience may use that.
But there are great similarities.
paper you did, was that technically called a thesis? see what happens. See.
These your peeps?
The tall guy that just walked in is my intern. He's hanging out with me this year.
Cool.
Just graduated from Rensselaer, and
deceiving. Appreciate it nevertheless. That's exactly it.
What do you do, Julie? What do you do?
I'm a psychologist at faculty in the psychiatry department. I do research on aging in the brain.
Oh, cool.
And menopause as well.
Oh,
My current grant
really?
is about aging, but
I'll call you.
I call myself. I know this.